for giving us this interesting instruction course, and Dr. Nikhil for giving me this interesting talk. There are no financial disclosures. I will be speaking on unilateral disc edema. And before we go into the talk proper, just a small slide about why do we use the term disc edema and not papilledema. You will see in the instruction course at most of the places, with or without an increase in the waist ICT, increase intracranial pressure. So therefore, unless until it is proven, it may be better to use the term disc edema rather than papilledema, and we may not be wrong even if it's a raised ICT to use the term disc edema. So what is the pathophysiology? The pathophysiology in patients where there is not a raised ICT is slightly different. So if you look at the ultrastructure diagram of the optic nerve here, we see all the optic nerve fibers, they are coming out at the optic nerve here, and within them there is the exoplasm. There is an active process through which the exoplasmic fluid is passing from the retinal side towards the lateral genicular body, and it is surrounded by the outside the eyeball. The optic nerve is surrounded by the sheath which contains the CSF. So if there is a raised ICT, that will compress the optic nerve. By compressing the optic nerve, there will be a compression of the exoplasmic flow, and there is a resultant disc edema. But in the cases where there is not a raised ICT, in those cases, this exoplasmic flow itself gets stopped because of the active process gets dysregulated. For example, in ischemia, there is a lesser ATP generation, and then in those cases, there will be a edema because of the swelling of the axons themselves. And there may be added factors. So these are the two mechanical and the vascular theories of disc edema genesis. Now before I come to unilateral disc edema, just a small slide telling that if you see a patient with two disc edema in both the eyes, the first thing which we think is that there is something going wrong in the brain, in the CNS. There may be a tumor, there may be a raised ICT, there may be a possible cavernosinus sinus thrombosis, or there may be a transverse sinus stenosis, and we generally think of doing a neuroimaging. But sometimes we may think of systemic conditions. I think this will be alluded to in greater detail in the talk by Dr. Satyakarna. But a case of hypertensive retinopathy. On the contrary, when we see a patient with unilateral disc edema, raised ICT, diffuse CNS processes, and systemic diseases are less likely. And we are more likely to have etiology which could be a local optic nerve or intraocular pathology. Or it could be an orbital or rarely a systemic disease that can be manifesting unilaterally. So if we look at these, we can classify those into four major categories. One can be optic nerve diseases or optic neuropathies. The intraocular inflammation, which may lead to unilateral disc edema. Sometimes it can be pseudodisc edema, which has been very well covered by Dr. Nikhil. And there can be asymmetric manifestation of a bilateral disease in some cases. So we'll be concentrating mainly on the optic neuropathies, and we'll discuss the others in brief. The four major optic neuropathies that are likely to cause unilateral disc edema are papillitis, ischemic optic neuropathy, neuroretinitis, and a compressive optic neuropathy. We'll begin with papillitis. The papillitis is actually one of the forms of optic neuritis, which includes both inflammation of the optic nerve head, which is called papillitis, or if it is behind the optic nerve, it is called as retrobulbar neuritis. This is a typical example of a patient with papillitis. You see in this picture on the right side of the screen, you can see that there is presence of disc edema, which is actually mild, but there is a graying of the palpebral nerve fibrillate throughout. There is a disc hyperemia as compared to the other side. So this is a patient with a unilateral papillitis. If you see this picture from some of those which were shown by Dr. Nikhil in the last presentation, something like this, what we can find is that in papillitis, the disc edema is only mild. There may be a mild vitritis. The vascular toxicity is not so much, and there are no signs of chronicity or maybe heart exudates such as the signs of vascular leakage. As compared to this picture, which is a patient with a true disc edema due to raised ICT. So you can see the presence of the deposits, hemorrhages, there is diffuse hyperemia with microtelangiectasias over the disc. However, this may be the case in the established papilledema, and it will be very easy to distinguish and say that this is not likely to be papillitis. But in an early case, there may be a little difficulty, but you may still get some other signs. So In those cases, we rely on the clinical profile of the patient also. So in these cases, if you see, in patients with papillitis, usually there is a profound loss of the vision, and it's an acute onset. On the contrary, papilledema patients, they usually complain of transient obscurations of vision, and it's usually an insidious onset condition. In addition, there may be other signs such as oculomotor paralysis, clear paralysis, loss of pulmonary sensations. And we alluded to these things that this edema is mild, may show vitritis in papillitis, whereas these are absent in patients with papilledema. And color vision is usually impaired in these patients. The exact pathogenesis of papillitis is usually a demyelinating process, which usually damages the myelin sheath, and thus there is a decrease in the conduction process. We know that in the case of myelin fibers, it's a solitary conduction which is fast, whereas when there is a demyelination at a particular area, the conduction stops over there. And as a result, it leads to profound visual impairment. The pathology in patients with optic neuritis can be an isolated disease or could be associated with some CNS or systemic disease such as multiple sclerosis. Sometimes, especially in the young children, it can be parainfectious in post-vaccination. So clinical profile of the patient showing a positive history of vaccination followed by this, or a history of fever followed by a decrease in the vision and disc edema, we should start thinking of possibly papillitis. Ancillary tests can help us. For example, visual fields, it may show a generalized reduction of sensitivity, which is the most common pattern, or sometimes there may be only a small paracentral scotomas which may be seen. But if we look at the literature, all kinds of visual field defects are possible in patients with papillitis. The diagnosis can further be helped by the VEP. The pattern VEP in these patients will show a reduction in the amplitude, but more importantly, it will show a prolongation of the P100 implicit time. What it means is that from the baseline, from the beginning till the peak of the P100 implicit time, the time that it takes is usually about 100 to 110 milliseconds. The standard deviation set for most machines is around 120 milliseconds. So if you see that this is more than 120 milliseconds, then it's highly suggestive of prolongation of P100 implicit time, and it is more suggestive of demyelination as I developed than any other. We can do imaging which will show a presence of a typical enhancement of the optic nerve on a contrast image, more likely to be picked up on a contrast image. And there may also be CNS changes in these patients. For example, there may be demyelinated plaques, especially in the periventricular area. And what is classically described is that there may be a radial orientation of these in the periventricular area, which is called as Dawson's fingers. So we'll stop on papillitis here, like how to diagnose it. We'll come to the next optic neuropathy, which is quite common, and is called non-arthritic ischemic optic neuropathy. This is again one of the very common cause of unilateral disc edema, which we see in middle-aged and elderly patients. If you see this kind of disc edema, this is different from what we saw before. You see, there is presence of disc edema, but the superior part of the disc is more edematous, and this is appearing very pale. So this is classically called as the pallid disc edema, which Dr. Nikhil also showed in one of his pictures. But sometimes it may not be classical, especially in the early stages. You may see a diffuse edema. The pallor may not have set in, and there may be presence of attenuation of blood vessels, and maybe presence of splinter hemorrhages along the disc. So these findings, which are suggestive of diffuse or segmental disc edema along with vascular attenuation, and maybe in very severe cases spreading to the peripapillary nerve fiber layer and maybe hard exudate deposition, are highly suggestive of a possible ischemic etiology as the cause of the disc edema. So in these cases, it is basically the occlusion of the posterior ciliary arteries that leads to the ischemia. It leads in the axonal exoplasmic flow and thus a swelling of the optic nerve head. As I said, it's more common in the middle-aged and the elderly people. There is no gender predilection here, but usually there are some risk factors, and sometimes a patient may not know it, but on your examination, if you send these for BP checkup, blood sugar checkup, coronary artery profile checkup, you may be able to pick up these risk factors. And usually there is a sudden onset decrease in the vision, and sometimes observant patients may say there is a sudden onset visual loss. And there may be sometimes a history of prior similar complaint on the other eye. So the diagnosis is aided by the presence of specific signs, reticular attenuation, segmental disc pallor, presence of concomitant changes of hypertensive or diabetic retinopathy, and the other examination may also help us. For example, there may be a small disc which is, like in this patient, there is a very small disc, you can hardly make out the top disc at rest. Or sometimes if the other eye was involved, there may be a diffuse or a segmental disc pallor with attenuated blood vessels. The visual fields are classically called as altitudinal field loss in these patients, which it means that there is a diffuse arcuate scotoma starting from the blind spot and reaching the horizontal. But it's not the only kind of visual field loss we may get. If you see a diffuse swelling, diffuse ischemic process has set in, we will see a complete advanced field loss and a total division plan. It's common to find in the neophthalmology clinics patients where we are confused between ischemic optic neuropathy and optic neuritis. Well, with the clinical profile of the patient, like patients being middle-aged and elderly in ischemic optic neuropathy, presence of risk factors such as hypertension, diabetes, coronary artery disease, and the presence of segmental disc edema are more in favor of ischemic optic neuropathy than optic neuritis. Visual fields, if they are typical, they may help us. And you can do a VEP where demyelination will show up formation of PNK duplicate times, but it may not be picked up on the patients with the ischemic optic. The other kind of unilateral disc edema is seen in neuroretinitis. Some people believe it's a type of optic neuritis, but usually it's a different pathology. There is basically a segmental disc. There is usually a disc edema along with presence of the macular radiating folds of hard HPS, which is a typical pattern. So in these cases, this macular star kind picture which happens is because of the resorption of the fluid, and it leaves presence of the hard HPS or in the macular area. And the vascular alterations may be one of the causes of unilateral disc edema. And if you look at the picture, you can hardly have any other differential diagnosis other than having a diffuse CRVO as cause of the disc edema. But sometimes in the patients where it's in early stage, it may be a little difficult. For example, in this patient, it's a patient with an incipient CRVO. The patient shows the presence of disc edema, there are hard exudates, there is presence of hemorrhages diffusely. In these cases, doing a FFA may help in the diagnosis. And this is the enlarged picture of the same patient which shows presence of disc edema along with cottonwool spots and ridges. Another cause of possible unilateral disc edema can be a reverse sensitive optic neuropathy. And in these patients, why it may be it's actually a mitochondrial disease where it's affecting the nerve function. Usually it's a sequential involvement of the optic nerve. So that is why we see it as a unilateral disc edema more often than bilateral. But sometimes it can have bilateral onset. The presentation is similar to optic neuritis, but here the visual acuity does not recover well. And if you do a FFA, you can see microtelangiectasis in the very early stages. That may be helpful. Some of the uncommon causes can be intraocular inflammations. For example, in this patient, if you see there is disc edema, but it's not the features are not confined only to the nerve. You see the diffuse RP changes over there, and if you see the montage of this patient, you can see presence of subretinal fluid in these areas. So this is that there is a diffuse inflammatory process going on. We did a B scan for this patient and found a classical T sign. So this was a patient with posterior scleritis causing a unilateral disc edema. I'll just rush through the remaining things because they are less common. But compressive agents sometimes can have unilateral edema if they are orbital, or it can be asymmetrical involvement in the CNS tumor. But in these patients, the onset may be more insidious. There may be history of trauma. There may be some specific orbital and other signs which may help. For example, in this patient, there is congestion. There is a little drooping of the eyelid, and this is the enlargement of the same. And we did a B scan found presence of a cystic lesion with a scolex, and this was actually compressing the optic nerve in this patient, causing the unilateral disc edema. Then in some of the patients, there may be presence of the reduced causal sensations. Sorry, the video didn't play, I think. And in some patients, there may be presence of motility problems along with a little thought process that may give us a suggestion that these may be having something else as a kind of disc edema. So neuroimaging and orbital imaging is very useful in these patients, and we can pick up patients having tumors close to the orbital apex, and sometimes simultaneous malignancy migrating into the optic nerve apex. Very rarely there may be a mucosal assisted lesion diagnosed causing a unilateral disc edema, and there can also be the presence of traumatic sequelae or myositis. So these are the main things which are the cause of the unilateral disc edema. Very rarely it may be because of some of the CNS causes if it's presenting early, and pseudo disc edema may be one of the causes. These are the main things which are the cause of unilateral disc edema. A specific approach detailing the history of the patient and a meticulous examination to ancillary findings may help us in the diagnosis. Thank you very much.